Greetings to everyone who is watching this video. Myself, Dr. Ramadass, Assistant Professor of Community Medicine in Sri Lakshmi Narayana Institute of Medical Sciences, Pondicherry. Today, the topic of discussion will be the epidemiology and control of tuberculosis. Tuberculosis is an infectious disease caused by Mycobacterium tuberculum. The most common mode of transmission is a droplet nuclei. There are types maybe of pulmonary tuberculosis and extrapulmonary tuberculosis. 10 to 15 percentage of the lifetime risk for the infected to develop the disease is there for tuberculosis. This graph shows the three high burden countries list for TB, TB and HIV and MDR TB, which is defined by WHO for the period of 2016 to 2020. If we see India is having both the high burden of tuberculosis, TB with HIV, and also MDR tuberculosis. And in the main methods that are used to estimate the TB incidence, if we see in India, most of the studies are prevalence studies and individual studies. And we are in the process of bringing out a nationwide prevalence survey. So estimated TB incidence in 2018 for countries with at least 1 lakh incidence cases. We can see the India comes under the category of around 2,500,000 incidence cases in 2018. So there are various methods that have been used for computation of these incidence and prevalence of tuberculosis. One can be the case notification or estimated proportion of cases detected, and the prevalence or duration of the disease. Then annual risk of tuberculosis infection, that is type loss coefficients, can be used. Deaths or proportion of incident cases that are trends of tuberculosis incidence. So we see in worldwide there is a decline in the incidence of tuberculosis. The notification of the tuberculosis cases has been on the rise. In India, recent decades found an increase in the notification of new and relapsed TB cases. Overall, it's a plateau for the incidence of tuberculosis. The burden of tuberculosis in India. In 2018, the total TB incidence was 199 per 1 lakh population. And the HIV positive TB incidence was around 6.8 per 1 lakh population. The MDR or rifampicin resistant TB incidence was 9.6 per 1 lakh population. And the HIV negative TB mortality is around 32 per 1 lakh population, and HIV positive TB mortality is 0.72 per 1 lakh population. Estimated proportion of TB cases with MDR or rifampicin resistant TB in 2018, the new cases was around 2.8%. Previously treated cases was around 14%. In the TB case notification in 2018, the total cases notified were around 2,155,894. So what are the risk factors can be for a tuberculosis infection and disease? So there are many factors. Out of this, the host factors are maybe due to immunosuppression, substance abuse, and nutritional status, systemic diseases, age differences, and gender. Children and old age are more affected, males are more affected. Social and environmental factors like household contacts, birth in a TB endemic area, community settings, socioeconomic status, and minority groups. Coming to the host factors, immunosuppression. Risk of acquiring TB is 9 to 16 times that of for in HIV uninfected individuals. The WHO estimated 10 million new TB cases in 2017, 9% of whom were people living with HIV. The large proportion of the global burden of HIV-associated TB occurs in sub-Saharan Africa, with 71% of new cases of TB and 84% of deaths. Effect of HIV on TB. The risk of TB doubles within the first year of HIV seroconversion due to rapid depletion of TB-specific T helper cells. Thereafter, the risk of TB progressively increases with declining immunity. Increased risk of developing TB, active TB from reactivated latent infection. Risk factors for accelerated progression of TB and the death following exposure. The risk of transmission is lower because of shorter duration in those put on positive. The risk of TB decreases with initiation of antiretroviral therapy. HIV-infected patients have an increased risk of recurrent TB after successful therapy, usually due to exogenous reinfection with old or new strains. Glucocorticoid therapy, diabetes, tumor necrosis factor inhibitors therapy, and transplant. Substance abuse is the most commonly reported behavioral risk factor among patients with tuberculosis. Relative risk of 1.5 to 2% for the development of TB for people who are involved in tobacco smoking, also associated with the risk of relapse and TB mortality. Both injection and non-injection drug use contribute to high prevalence of tuberculosis among drug users. Alcohol risk of active TB is substantially elevated in individuals who consume more than 40 gram alcohol per day. This is due to the effect of alcohol and alcohol-related conditions on the immune system. Malnutrition is generally understood to be an important risk factor for tuberculosis. Persons who are underweight have increased risk for TB by a factor of 2.6. Vitamin D plays an important role in macrophage activation and restriction of mycobacterial growth, and diminished serum vitamin D levels appears to increase risk for TB infection. Iron is an important growth factor for M. tuberculosis in macrophages and appears to play an important role in host susceptibility to TB infection. Silicosis. The relative risk depends on the severity of the silicosis and has been estimated at 1.4 to 2.9. The risk of TB is increased in patients with hematologic malignancies and head and neck cancer, diabetes, renal disease or gastric surgery, celiac disease, cirrhosis, COPD. Aging in the developing world, TB rates are highest among young adults, reflecting primary transmission in this age group. Gender among HIV uninfected individuals, the rate of TB is higher among men than women. In the social and environmental factors, 7 countries account for the majority of cases of TB in foreign-born persons in the United States, namely Mexico, Philippines, Vietnam, India, China, and the Dominican Republic and Haiti. Close household contact with an individual with smear positive pulmonary TB is the most important risk factor for tuberculosis. In places where contact with infectious individuals may occur, the risk for acquiring TB infection is increased. Crowding and poor ventilation can increase the risk of transmission in such settings. Those at risk for increased risk exposure include residents and employees of congregate settings such as hospitals, correctional facilities, nursing homes, and homeless shelters. TB has traditionally been associated with low socioeconomic status, which also may be associated with crowding, poor nutrition, poor access to medical care, public assistance, unemployment, and low education. TB disease rates among racial and ethnic minority groups are 5 to 10 times higher than among whites. These groups comprised 83% of all reported TB cases in 2007. So, the background of tuberculosis control in India. In 1946, Boer Committee recommendation to the Government of India to set up TB clinics in districts and mobile TB clinics in rural areas. In 1947, Government of India established TB division under the Director General of Health Services in the Ministry of Health, planning and execution of anti-TB activities. In 1951, mass BCG vaccination campaign covering 65 million children in collaboration with IUAT was conducted. 165 million tuberculosis tests were administered to find the prevalence of TB in India. In 1955 to 1958, under ICMR, National Sample Survey to find the magnitude of the problem was undertaken. Tuberculosis Research Center established in Chennai improved the efficacy of domiciliary treatment for TB with chemotherapy. In 1959, National Tuberculosis Institute, Bangalore, by Government of India was established with active cooperation with the WHO to develop TB control program. In 1962, National TB program was launched. Then in 1993 to 1997, DOTS, Directly Observed Treatment Short Course, was piloted. In 1997, RNTCP was launched. In 1998 to 2006, scaling up of DOTS was done. In 2006 to 2015, initiatives based on Stop TB strategy was carried out. And recently, National Tuberculosis Elimination Program was started. Notable initiatives before 2015: initial mandatory notification of all TB cases was done. Prohibition of sero-diagnostic kits was carried out. Public-private partnerships were strengthened. Standards for TB care in India was implemented. Collaboration of National AIDS Control Organization and revised National Tuberculosis Control Program was started. In the post-2015 Global Tuberculosis Strategy as a glance, the vision was to establish a TB-free world with zero deaths, disease, and suffering due to TB. The goal was to end the global tuberculosis epidemic. Milestones for 2025: 75% reduction in TB deaths compared with 2015, 50% reduction in TB incident rate, less than 55 TB cases per 1 lakh population, no affected families facing catastrophic cost due to TB. The targets for 2035 were 95% reduction in TB deaths compared with 2015, 90% reduction in TB incidence rate, less than 10 TB cases per 1 lakh population, no affected families facing catastrophic cost due to TB. For this, the principles were to government stewardship and accountability with the monitoring and evaluation, strong coalition with civil society organizations and communities, protection and promotion of human rights, ethics, and equity, adaptation of the strategy and targets at country level with global cooperation and collaboration. The pillars are integrated patient-centered care and prevention. Early diagnosis of TB, including universal drug susceptibility testing and systemic screening of contacts and high-risk groups. Treatment of all people with TB, including drug-resistant TB and patient support. Collaborative TB or HIV activities and management of comorbidities. Preventive treatment of persons at high risk and vaccination against TB. Second pillar is a bold policy and supportive systems. Political engagement with adequate resources for TB care and prevention. Engagement of communities, civil society organizations, public and private care providers. Universal health coverage policy and regulatory frameworks for case notification, vital registration, quality and rational use of medicines, and infection control. Social protection, poverty alleviation, and actions on determinants of TB. Intensified research and innovation, discovery, development, and rapid uptake of new tools, interventions, and strategies. Research to optimize implementation and impact and promote innovations. Promote innovations. The WHO theme for World TB Day on 24 March 2019 was "It's time" to scale up access to prevention and treatment, to promote equitable, rights-based and people-centered TB response, ensure sufficient and sustainable financing, including for research, promote an end to stigma and discrimination, build accountability. In 1997, RNTCP launched as a program national-wide in a phased manner, adopted internationally recommended directly observed treatment short course strategy. The components of RNTCP is a strong political will and administrative commitment, reliable and early diagnosis through smear microscopy, uninterrupted supply of good quality drugs, effective and patient-friendly treatment given under direct observation, proper recording, reporting, and supervision. The organogram of RNTCP under the Ministry of Health and Family Welfare, There is a health secretary and director general of health services. Under the health secretary, there are additional secretary and joint secretary. And then additional director general of health services forms the central TB division. Under the central TB division, we have state TB cell in each state, district TB center for each district, and under the district there are tuberculosis unit. There is a one tuberculosis unit per block or one tuberculosis unit, one per 1.5 to 2.5 lakh population in urban areas. Under the tuberculosis unit, we have designated microscopic centers, one designated microscopic center for 1 lakh specimens. There are DMCs, that is designated microscopic centers, for one per 1 lakh population or 0.5 lakh population in tribal hilly areas, desert and difficult areas. Under the designated microscopic centers, we have peripheral institutions like PHCs, primary health centers. So under the RNTCP, that is the Revised National Tuberculosis Control Program, we have the objectives to achieve at least 85% cure rate among new smear positive cases initiated on treatment, and the case reduction rate of at least 70% of such cases. Additions to RNTCP over National Tuberculosis Program was Sub-District Supervisory Unit, that is TB Tuberculosis Unit, and decentralization of both diagnostic and treatment services, and treatment under the support of lodge providers. Then of the Millennium Development Goals to halt and reverse the incidence of TB, reduce the prevalence and death rates to less than 50% by 2015, treatment success rate at or above 85%. WHO Stop TB Strategy of 2006, six principal components: DOTS expansion and enhancement, address TB or HIV and MDR and other challenges, health system strengthening, engage all providers, empower patients, communities, enabling and promoting research. The National Framework for Joint TB or HIV Collaborative Activities in 2017. In 2012 to 2017, we had National Strategic Plan. Vision was for a TB-free India, furthest universal access to quality TB diagnosis and treatment for all patients in their community, to achieve 90% notification rate for all cases, to achieve 90% success rate for all new and 85% for retreatment cases, to significantly improve the successful outcomes of treatment of drug-resistant TB cases, to achieve decreased morbidity and mortality of HIV-associated TB, to improve outcomes of TB care in private sector. Nikshay was launched in it's a web-based platform for TB notification system of public and private health systems. Post-Millennium Development Goals, we had Sustainable Development Goals, the global strategy and targets for prevention of TB care and control endorsed by all member states at 2014 World Health Assembly. To achieve the targets, NTB strategy spells out pillars and its components. We have discussed some of these in our previous slides. And the vision was to have a world free of TB. And the indicators, three important indicators were to reduction in number of TB deaths compared with 2015, reduction in TB incidence rate compared with 2015, and TB affected families should not face catastrophic costs due to tuberculosis. Under the NTB strategy, we had certain pillars and components. Then the mantra for detect, treat, prevent, and build approach. Although India has managed to scale up basic TB services in the public health system, treating more than 10 million TB patients under RNTCP, the rate of decline is too slow to meet the 2030 Sustainable Development Goals and 2035 NTB targets. Continuation of prior efforts have yielded inadequate declines and will not accelerate the progress towards ending TB. New comprehensively deployed interventions are required to hasten the rate of decline of incidence of TB manifold to more than 10 to 15% annually. Detect, treat, prevent, and build. Tuberculosis Laboratory Services Framework. It is a three-tier system for provision of diagnostic services and maintaining its quality. Peripheral laboratories, dispensaries, PHCs, CHCs, referral hospitals, major hospitals, specialty clinics, TB hospitals, medical colleges, and in the private NGOs. Physical infrastructure and binocular microscope and a trained laboratory technician. At the state level, IRL usually situated in the State Tuberculosis Center and monitoring lab services and maintenance of its quality through external quality assessment. At the central level, National Reference Laboratories, NIRT Chennai, NTI Bangalore, NIRTD, NITRD Delhi, Jalma Agra, RMRC Bhubaneswar, BMHRC Bhopal, external quality assessment of lab network, drug resistance surveillance training and research. And the diagnostic tools, put and smear microscopy for AFB, Zeal lens staining and fluorescence staining. Rapid molecular diagnostic testing, line probe assay for MTB complex and detection of rifampicin and INH resistance. NAT expert or MTB or ref testing using the gene expert system. Solid J medium automated liquid culture systems like Bactec MG18 drug sensitivity testing. Modified PST for MG18 first and second line. This is the form that is required for diagnosis of TB, drug sensitivity testing and follow-up. Patient offered drug sensitivity testing based on criteria of presented depression TB patients. 4 sets of drug sensitivity patterns will be offered based on availability of drug sensitivity services. Rifampicin alone, isoniazid and rifampicin. Detail the first line pattern with isoniazid, rifampicin, ethambutol, and streptomycin. If a first line liquid DST is used, medical officer should record weight, height, BMI indicating liquid dosage depending on body weight and weight bands. Point of care non-sputum test to identify all forms of TB. These are not that much important. Maybe we can go through it. Urine antigen detection, that is lipoarabinol. And these are not used at the program level. And in 2017, we had urine test, then newer initiatives in detection of TB. This we can continue in our next session.